Thank you, Dr. Konvalinka, for that introduction. So I'm Slaghaniya, and I'm a PhD student in Dr. Konvalinka's lab. And go next. My project is investigating hepatocyte nuclear factor 4 alpha as a central regulator of kidney graft repair. So kidney transplantation is the optimal treatment for end-stage kidney disease. However, ischemia reperfusion injury, or IRI, affects all transplanted kidneys and can damage the mitochondria. And as Dr. Konvalinka mentioned, normothermic ex vivo kidney perfusion, or NEVKP, is a novel storage method that results in greater graft function when compared to static cold storage. So previously, we did a proteomics analysis of porcine kidneys that were either stored with NEVKP, static cold storage, and we found that the kidneys were stored with NEVKP had key mitochondrial proteins increased, and further analysis using integrated databases predicted that these mitochondrial proteins were predicted to be regulated by this transcription factor called HNF4 alpha, or hepatocyte nuclear factor 4 alpha. And so the goal of my project is to determine if a novel HNF4 alpha agonist called N-transcaffeoyltyramine, or NCT, can protect kidneys from injury. So my hypothesis is that NCT preserves mitochondrial function and proximal tubular cell viability in vitro and will ameliorate kidney injury in a model of bilateral renal IRI in vivo. And so to do this, we've inhibited HNF4 alpha first to study its function in the proximal tubular cells. And when we did this, we saw that there was an increase in proximal tubular cell death and a decrease in mitochondrial function. And so in my subsequent studies, I'll be giving NCT to proximal tubular cells and looking at cell viability and mitochondrial function, as well as administering it to mice prior to bilateral renal IRI and looking at kidney function and the development of fibrosis, as well as looking at cell-free mitochondrial DNA. And so we have patient partners from the Canadian Donation and Transplantation Research Program, CDTRP, where Dr. Konvalinka is a co-lead for the theme called Engineer and Allocate Better Grafts. And we'll have patient partners that contribute to manuscripts and discussions, as well as with the goal to improve the health and longevity of kidney transplants. And so that leads me to my conclusions that if NCT is successful in vivo, it can be readily translated to patients. It can be administered during ex vivo during organ storage. And if NCT is successful, it can improve graft outcomes by decreasing delayed graft function and improving the quality of life for patients. And so that brings me to my conclusions. I would like to thank my supervisor, Dr. Konvalinka, as well as my lab mates and collaborators. And thank you for listening.
Let me introduce the last speaker, and we have Rohankrishna Harikumar, and he will be speaking about the role of RO in PKD-mediated mitochondrial remodeling.
Hello, everyone. Yes, so today I'll be speaking about the role of ROA in mediating mitochondrial remodeling in polycystic kidney disease. A little bit of a background on PKD, or polycystic kidney disease. It is the most commonly inherited renal genetic disorder affecting around 1 in 1,000 people worldwide. And this is progressive, meaning that there is no way to cure it, and it eventually leads to end-stage renal disease, in which treatment options are largely limited to organ transplantation or dialysis. And in the literature, there have been recent studies that show significant mitochondrial damage in PKD conditions, under PKD conditions. So this led us to focus on the role of mitochondria in mediating the different phenotypes of PKD. And the two main phenotypes, as you can see on the kidney on the right, is a large swaths of fibrosis within the kidney, which destroys regular renal tissue, and cysts that punctuate the surface. And so our research plan functionally revolves around looking at mitochondrial fragmentation as a downstream consequence of polycystin loss. And through this exploration, we've landed on ROA, which is a small GTPase, as the crux of this entire mechanism. So we believe that upon the loss of the polysystem protein, which is a case in PKD, we have an increase in Rho activation, which then goes down two separate pathways, which then join together through the action of DRP1, which is a dynamin-related protein, to then go ahead and fragment the mitochondria. And this mitochondrial fragmentation, we hypothesize, has functional consequences down the line, including but not limited to renal fibrosis. And so we used MITO2i's and a software known as Imaris to basically convert our confocal images to volumetric shapes, so we can very easily quantify mitochondrial volumes. And we used a myriad of different methods to play around with these different factors, including siRNA and pharmacology. Just a couple of results, because we're short on time here, we've shown that a loss of the polysystem protein significantly increases mitochondrial fragmentation in a Rho-dependent manner. And we've also shown that the dynamin-related protein DRP1 is translocated to the mitochondria upon PC or polysystem loss in a Rho-dependent manner. So just two sample data because we're short for time today. In terms of patient engagement, my research is largely focused on just the basic science, but of course, we are reaching out to the PKD Consortium and the Kidney Foundation of Canada to better translate our evidence research to the general population. Again, our end goal would be to ameliorate PKD and the other chronic kidney diseases. And so this small weapons research is one rung in the ladder that leads to that progress. So again, patient engagement is important, and we are focused on translational research. Finally, understanding the mechanisms that govern mitochondrial fragmentation in PKD allow us to eventually target specific mediating factors. And this may lead us to generate therapeutics down the line, which allow us to alleviate fibrosis or cystogenesis down the road. And this will allow patients to wean off of dialysis or reduce the load or burden for kidney transplantation. Thank you very much to my lab, the Kappas lab, and the collaborators shown here. And thank you to MITO2i.